Okay, I'm a psychosomaticist, and it's a own specialty in Germany, like psychiatry or surgery or something like that. Yeah. And after finishing medical studies, yeah, we have 5 years for this specialty, 5 years, yeah, 3 years inpatient treatment, and 1 year internal medicine, and 1 year psychiatry. And our psychotherapy training is rather intense, yeah, uh, and it's also our main way of intervening with the patients. And it's a little bit different to the psychiatrists. They are mainly treating with biological methods like medication or something like that. And in Germany, we have very many psychosomatic departments. Yeah? We are treating patients with eating disorders, patients with medical disorders like coronary heart disease or something like that, and mental health problems. And on where I work, I'm working on a ward for young adults with severe personality disorders. And most of them have also chronic depersonalization, yeah, and very complex problems. Yeah. And also we have an outpatient clinic and consultation liaison psychiatry or psychosomatic medicine for the other departments in the university hospital. Yeah. I am engaged in education of medical students and of trainees. Yeah? And we also have an institute for training psychodynamic psychotherapy for psychologists. Yeah. When I personally started my career, I found it very difficult to understand how psychotherapy works. Yeah? We were reading a lot of psychoanalytic books, but it was very difficult to translate it to treatment and to understand the symptoms of the patients. And so the triangles were extremely helpful, yeah? To understand how in the moment the symptoms are built up, yeah? and to understand and to make it understandable also for the patient. And also the manual had a lot of examples how to intervene, how to say what, yeah? And this is totally missing in most books for teaching psychodynamic psychotherapy. And also the concept of affect phobia is very easy to understand, I think, for most people. Yeah? And for the patients, it's even more easier to understand because they know their problems much better. Yeah? The language barrier is somehow existing because some trainees said, if it would be in German, I would read it. And so I decided to translate it, yeah. And it was a good exercise for me. I translated every day about 2 or 3 pages, and so in a year it was finished. Yeah. You know the video of Michal,
yeah.
The APA series, and
yeah.
I always show it to the students. And half of them are embarrassed. And they think, oh, what is she doing? Why is she so cruel with the patient? Yeah.
Yeah.
And she's giving her no room and so on. So it's these kind of approaches are not so easy for a lot of students to accept or to feel comfortable with it. Yeah.
Yeah, I know in the United States, when I have shown Lee's work or my work, people will get very uncomfortable by how quick the process is.
Yeah.
Like, how can you know within 3 minutes that someone's conflicted with this affect? Like, how can you really know? And why aren't you asking more questions? And why aren't you listening more? And so you know, people will get uncomfortable by how quick the process is. At least that's been my experience here in the United States.
So do not think it's a cultural thing. It's a more of our own affect phobias.
Mm-hmm.
Yeah. But of course, they are also mixed with culture. Yeah.
Absolutely.
Psychoanalytic culture is very strong in Germany. Yeah. And I think most of them don't like approaches like that.
From my witnessing people's reactions and when they meet APT, I think within the caring profession, we come often from a place of experiencing narcissistic rage in a parent, or a place of not being well cared enough for as a child. I think by making something so simple and so accessible, it removes that narcissistic aspect for therapists. They can't feel as, the grandeur or the brilliance of which some therapists want to feel. You're really meeting the client and giving them the map at the same level, which could be quite frightening for some, but you're also asking therapists to work second by millisecond, rather than some therapists work looking at people's themes in life over months or years, and not looking at the micro facial expression, the change in the color of the skin. And maybe that they feel that's intrusive, but I think it is an affect phobia on the therapist's part, as well as a loss of a bit of esteem.
And that's why Ed Tronick's work is so exciting, because he's really talking about, the therapeutic relationship being, the opportunity to repair ruptures, right? And that we're learning from APT, ISTDP that, if we're in an intellectual defensive stance, then we're not able to connect with another person. And so, these models are inviting both patient and therapist to be really focused on, what are we able to experience emotions together in this moment? And if you stay in an intellectualized position, it's impossible to make that happen. We all have, really good ideas about what can be happening for someone, but it's not until we're actually working with affect that we discover what's true or not. And, what I love from the video segments that we watch is when someone's able to experience affect, right afterwards, you see a memory that arrives. And in that memory, there's more information to begin to work with. And so you kind of like move from affect to affect, and the more someone's able to experience affect, the richer their story becomes. What did you notice happening for you in this process?
I became, I think, more self-confident and more, how to say it in English, more relying on my own emotions. I think it's also helping to overcome the own affect phobias, yeah. And I think that was a result, but also with the ICDP training, yeah.
Yeah, and I mean, in APT, we are always talking about therapist affect phobias, and in our consultations, we're certainly focusing in on resolving them too, if it gets in the way of treatment. So it's a little bit different than saying, well, we're trying to resolve all our emotional conflicts. It's more like, well, if they get activated in treatment, what is it that we need to do in order to like be able to work more openly with our patients. So and it seems as the years go on, we hear about affect phobias and therapist affect phobias. It's like they come together. So
yes, but not only in therapy. Reading the newspaper in the bus, every time emotions come up, yeah, or at home, yeah. So
does it bring up, Matthias, does it bring up the sense of Gemeinschaftsgefühl?
Yeah.
Okay.
Gemeinschaftsgefühl and also more reliance on the, I don't know if it's a good word in English, natural healing forces in ourselves. Yeah. So everything is there. I don't have to bring something in. Everything is there, and just you help the patient to become aware of what is inside him. Yeah.
Yeah. Yeah. So the natural healing and also the kind of fellow feeling for the other, self and other.
Yeah. If you can remove the obstacles between you and the other persons, between your true emotions and
Yeah. I'd love to hear how you connected depersonalization with affect phobia. I'd love to hear how.
Yeah, because have you ever treated patients with depersonalization disorder?
Yeah.
And they are really, most of them are really difficult to treat because of, and in the beginning, when I started research and treating patients with depersonalization disorder, it was really very difficult for me to reach through to the patients. Yeah. And with this affect focus, it's really much more easier. It's still a severe disorder, yeah, but it's much more easier to understand them and to help them feeling their feelings, yeah.
Absolutely.
And this approach, you can, for example, on our ward, we have I don't know if it's a correct English word, we have a visit every week where the senior physician is visiting the patient in his room, yeah? And even in these 10 minutes, we can use the triangles and try to reach through the patient, yeah?
The people that I work with, I encourage that they record the sessions so that they can go back and watch. And I have found that the people that I work with who have depersonalization, like it's fascinating for them to watch the video recording of their psychotherapy session and then come back the following week and be like, oh, I could really see what you were noticing in that moment. But in the moment, I couldn't so much, you know? And so the video recording offers like another opportunity for them to see, you know, how they detach and then, you know, and how they come back into connection. So.
I have no experience with showing the patient, not so much experience with giving the patients the videotapes, because it's not allowed in our department.
Right.
We only can show them the video and sitting by them. Yeah.
Yeah. Yeah. That's very powerful to do with patients too. So for sure.
And can I ask you, Matthias, do some of the patients move between defenses? Do they somatize or depersonalize, or is it more depersonalization as the primary defense and then a backup defense is somatization?
It's usually when the depersonalization becomes weaker, they have more somatic symptoms.
Yeah.
And and of course, we have rotating defenses, especially when they are inpatients, because they project a lot of, they split and
We find that with when Kristin runs trainings, I'm her apprentice, that after a few days, when the depersonalization defense goes away, the trainees all come in with back pain or stomach pain or neck pain, and you'll see it active in the group as a defense. It's fascinating. In a group, the defense gets mobilized once the depersonalization goes down. Yeah. It's almost like they're in the trust-mistrust phase, like a toddler. Do I trust this process or not? And they somatize like a child would, but they're adults. So we don't hide it. We say, explain to them. Do you notice that everyone's moving into somatic defense? And are you interested? Are you curious about how this has arisen? What happened last night? What happened in people's dreams? What happened? And get people curious about it rather than frightened.
If somebody wants to do this, do you have any recommendations? If somebody wanted to translate the APT manual in their country, do you have, or any other manual, do you have any recommendations about the process of, like, you know, finding a publisher and making it happen?
This time it was not What was not difficult? Maybe because I've written a book for patients, which is selling very well, yeah. And so maybe they trusted me, and I did not earn anything, yeah. So they had not a high risk, yeah. And so it was not difficult. Also, the other project, Hidden from View, it was not so difficult, but now we have to wait how it's how the public will accept it and buy it. Yeah. So I think it's good to know to know publishers and to have a connection to publishers. That would be helpful.